Settled in. There we go. All right. Well, welcome everyone. Thank you for joining us for our very first Wound Scene Investigation Chronicles. It's been a long thing coming with the Wound Healing Society, Lisa and Rummana, everybody working so hard on pulling this together. So happy to have you join us today. My name is Weir. I'm a wound care nurse and I'm the co-chair of the Symposium in Advanced Wound Care. And I'll tell you my role that I played in wound scene investigation in just a few moments. But I think before I do that, I'm going to have the rest of the panel introduce themselves. So Bob, you want to go next?
Okay. I'm Bob Diegelman. My title is a Distinguished Career and Emeritus Professor of Biochemistry and Molecular Biology. I just retired last January 1st after 49 years at VCU School of Medicine.
All right, Lisa?
Hi, I'm Lisa Gould. I consider myself a wound surgeon. I'm plastic surgery trained, and I treat only difficult non-healing wounds, both in the outpatient and inpatient arena. Former president of the Wound Healing Society, so many of you have seen my face, and a longtime participant in wound scene investigation.
All right, Greg.
Well, hello, everyone. I'm Greg Schultz, and like Dr. Diegelman, I am an emeritus professor now at the University of Florida, where I was the director of the Institute for Wound Research. Like Lisa and Bob, I was also president of the Wound Healing Society for a couple of years and had the wonderful opportunity to participate in the wound scene investigations from the beginning. And it's a real joy and privilege to go back with my colleagues and review some of the critical things that were presented in those chronicles, in those initials and in these chronicles to sort of update it for you.
And last but not least, Rummana. You're muted, Rummana.
Hello and welcome everyone. We are very excited to present this webinar today. I'm with the Yale School of Medicine. I'm the Chief of Physical Medicine Rehab there, as well as Director of Wound Care. I've been with the Wound Healing Society for more than 20 years, I am chairing the Education Committee currently, which is the committee presenting this webinar today. And then I will pass on to Lisa to introduce actually, I will have to pass on to Dot and Bob to start telling us the history of wound scene investigation.
Okay, and I failed to tell you where I am. I'm a wound care nurse and I practice at the Saratoga Hospital Center for Wound Healing and Hyperbaric Medicine in beautiful but cold Saratoga Springs, New York. So Dr. Diegelman, let's tell them how we got this thing started. So we plan our SAWC spring meetings every June of the previous year. So we were sitting in a meeting in 2006 and planning the 2007 meeting, and Dr. Diegelman leans over to me and says, you know what we need to do? We need to have a session called Wound Scene Investigation. So Bob, tell them how you even came up with that name.
Well, initially we called it the bed to bench process.
Bedside to bench.
Normally you go bench to bed, we go the other way, bed to bench. So clinicians are used to trial and error mostly to figure out how to treat these chronic wounds without really understanding the basic science behind it, the cell biology, the biochemistry, the molecular biology. So we thought, wouldn't it be nice to take a known situation in wound care and dissect it apart and tell the clinicians what's going on at the microscopic and cellular and biochemical level. So that's how we sort of got started, to make like teaching rounds. And I had this idea because when I first came to VCU School of Medicine in 1972, working with Kel Cohen, he used to take me on clinical rounds with the residents and fellows. And we'd look at a wound and then he'd tell me what the clinical approach was to that wound. And he says, Bob, what do you think's going on here? So without any data or information, I would kind of speculate on what I think is happening. I say, well, that wound's granulating. That means it must be full of macrophages by now. And the macrophages are giving off important growth signals like TGF-beta and PDGF to enhance the vascularization so that that wound can go on and heal. And as we went through the different patients, we talked about how some wounds heal by matrix deposition, acute wounds, for example, contraction, like the pressure ulcers, and epithelialization. So today we're going to focus in on epithelialization. So basically, we were trying to dissect the wound back down to the elements, like the most fantastic voyage, going through the tissues to see what's going on.
Absolutely. And it was such a fun journey. So our first panel was the four of us that you see here, and then Lillian Nanny, who is a PhD in anatomy from Vanderbilt University. And then she retired, and Dr. Lee Ritzy joined us to finish out our stint as we did it. And interestingly, the wound scene investigation also came from a company who was giving out bags out of the exhibit hall that had wound scene investigation on it. So anyway, so we had a wonderful journey. We did it twice a year from 2007 until 2019, I suppose, or 20, the first virtual. We did one more and then we retired it. So I thank you all. It's been a wonderful journey. And so we're going to start tonight by sharing the chronicles of wound scene investigation. So now, Rummana, I will turn it over to you. Oh, no. Oh, sorry, Lisa, you're going to give some more information about that. Sorry about that.
No problem. Go ahead, Lisa.
Yeah. So tonight we're going to show a flip book, and you might say, you know, why did we have a flip book? Well, at the Wound Healing Society meeting in 2017 in San Diego, if you saw us, we would be preparing wound scene investigation always at the last minute. And so we were crowded around a table brainstorming how we were going to get this done in the next 15 minutes before we have showtime. And I was waxing poetic, and I said, you know, we're getting close to 10 years. We've got somebody retired. We've got a few getting close to being emeritus professors. We better hurry up and log this in some way. And I said, what if we did chronicles of the wound scene investigation and created a book? And everybody thought, yeah, that's a cool idea. Go for it. And then I said, I don't know how. So I was like, well, let's brainstorm and I'll figure. And I had a picture in my mind of a book, but then Rummana became the education committee chair for the Wound Healing Society. And she and I were talking, and she researched it and said we could do an electronic book. And then she found these flip books, which we thought were really, really fun. And we got permission from HMP because these were all presented at the SAWC, and they said, yeah, sure, go for it. And so we launched the idea of creating this Chronicles of Wound Scene Investigation. And what you'll see is that we start at the very, you know, kind of near the beginning of wound scene investigation, 2010, 2011. And we go year by year. And in the flip book, we've tried to remain true to the original production. So we're not adding in new science. So the 2011 that you'll see tonight is what we knew in 2011. And if we repeated a topic, say 3 years later, we found new stuff. We always kept this as a fresh presentation. We might have repeated the topic, but we kept it as fresh as possible. So I'm going to show you how to get to this if you haven't already been there. Hopefully I'm still in there. It looks like it logged me out. Let's see. Share screen. No, that's not what you want. Stop share. Shoot. Why does it do this to me? Sorry. Let's see. So if you're going to go to look for the flip book, you're going to go to woundheal.org. And now I have to ask if
tab at the top of your screen.
It's what?
I thought I saw the tab at the top.
Yeah. Okay. So now I've got it. Here we go. So you're going to go to the Wound Healing Society webpage, woundheal.org. And whether you're a member or not, you could obviously dial into woundheal.org. And I'll bring that up. And so you'll go to Wound Healing U. Everybody, you can see that, right? Yeah. So you go to Wound Healing U. If you're not a member, you can see a sample, but you won't be able to get the whole flip book and the whole Wound Healing U. So you would click Join Wound Healing Society. But if you are a member, you can log in and you can view the chronicles. And what you'll see is the directory And this is what we have up so far, but there'll be more coming. And by the years, but you can also look at the topic. So for example, tonight we're going to do epithelialization, and there are 2 years listed, but you might be more interested in infected sternal wounds. So you would click on that and it brings up the flip book, and you can flip through the flip book. So, and it's just, it turns the pages just like a book. Pretty cool, huh? So we're really excited about it. And we hope that if you're not a member, you'll take a look at the tantalizing little tidbits and you'll say, oh boy, if I could only have more of this, because it's a huge compendium of cases and it's a great teaching tool. All right, I am going to figure out how to stop sharing my screen. There we go. And I'm going to turn it over to Rummana.
Okay. Well, welcome everybody. So we are presenting the topic of epithelialization. Epithelialization, what is it? So keratinocytes are the major cellular components of epidermis, the superficial layer of the skin. And they are responsible for restoring the epidermis whenever there's an injury. And this process is called epithelialization. So I am going to present the Chronicles of Wound Scene Investigation from 2011 and with updates in 2014. There's a little delay in starting this, so let's see.
Did you click in the screen?
Yes, I'll click on the screen. Okay. Okay, I know it worked before. Oops, okay. Something's working. All right. Let's see now. So what did we know in 2011? Somehow this is not advancing for me. I'll try my best. There is poor epithelial migration and attachment if the epithelium is not attached to the base of the wound as shown here, and there is instability. Okay. Is there anything that I'm doing wrong that this is not advancing? Somebody help. Can everybody hear me?
Yep, you're good. Just keep
going. How?
Yep, just don't click too many times if it's
Okay.
just taking a minute to catch up.
All right. Click again. Okay. So when the edge is separated from the wound bed, as you see in this picture here, the epithelium does not migrate. And when it is attached to the wound bed, there is robust migration. I have to use my mouse pad too. Epithelial migration occurs very rapidly when there is good wound preparation as seen here within a matter of days. So keratinocytes are born dancers. They love to dance. And here I will have Dr. Diegelman present the keratinocyte dance.
Okay, as shown here on the leading edge of the filopodia, these epithelial cells, there's a dynamic reorganization of the actin filaments at the edge of the cell. Now, this actin molecule is basically the same actin we have in our own skeletal muscles, but each cell has this as well. So that requires ATP for generating energy. And as you see, it's a very dynamic process where the filopodia of the cells reach out and move across the plane. The cells, these are free-floating cells right here, but on the attachment, they reach out, and if they come in contact with another identical epithelial cell, then they become the process called contact inhibition. Now, normal cells like the keratinocytes will stop dividing and proliferating and moving when they reach contact inhibition, whereas tumor cells will completely overgrow each other. So this shows how the epithelial base is being formed. Now, in chronic wounds, they prefer a basal lamina in order to attach to. They will not attach to collagen type 1. So the basal lamina has to be formed before the cells, the epithelial cells, can move across, migrate, spill into the wound by a process called epithely, and form a new epithelial layer. I think that's enough.
Okay. All right. Let's see if this helps. Okay, we are working. This was a study published in 1992 and was a clinical trial where sequential biopsies were taken from margins of venous leg ulcers during their healing. And the researchers showed that there was significant histological differences when the biopsy was taken from the non-healing ulcer as compared to the healing ulcer. And the major difference was that there was no fibronectin in a non-healing ulcer, and there was more increased levels of fibronectin in the healed ulcer. And fibronectin is a protein that is produced by granulation tissue and is essential for cell adhesion and migration. So when there is no granulation tissue, as in the non-healing ulcer, there is no fibronectin deposited and there is no epithelialization. And compared that to the healed ulcer, there is robust granulation tissue. And so increased levels of fibronectin are deposited and there is complete epithelialization. In a cutaneous healing wound, the epidermal cells or the keratinocytes here avoid the fibrin in the fibrin clot. This is the blood clot rich in fibrin. They do not adhere to the fibrin. Instead, they start migrating downwards over the granulation tissue rich in fibronectin. And the reason was shown in this study by Kubo et al. That fibrin and fibrinogen are anti-adhesive for keratinocytes. And the reason is that the keratinocytes do not have the receptor for fibrin. And they did experiments where they looked at the migration of keratinocytes over different protein surfaces coated with different proteins and showed that there was increased migration of keratinocytes on collagen and fibronectin, and there was no migration of keratinocytes on fibrinogen. Here, they looked at adhesiveness of keratinocytes on plates coated with different proteins, but they took two different types of keratinocytes. So these cells, these keratinocytes, they experimentally modified so that they had the fibrin receptor, and these are normal keratinocytes that do not have the fibrin receptor. So in this cell adhesion assay, there was no adhesion of normal keratinocytes to fibrin. All keratinocytes adhere very well to fibronectin and collagen because they have the receptors. When there is a thick yellow eschar in a wound, the keratinocytes will not adhere to this eschar because they don't adhere to fibrin, and there will be no epithelial migration. Even in a wound with a thin layer of slough, this has fibrin in it. So unless we remove this slough, the keratinocyte migration will not occur. In 2010, there was much excitement about TGF-beta as a key role player in many processes of wound healing, including epithelialization. TGF-beta is a protein produced by all white blood cells, and this paper showed the difference in TGF-beta signaling in healthy skin as compared to chronic wounds where the signaling mechanism was deregulating and basically shut down because there was a different morphology of the epidermis. Going to 2014, we maintained that these processes are very important in good wound preparation, but now more focus was being paid and attention to the migrating wound edges, and it was found that if you don't have migrating wound edges, the wound is not well prepared and healing would not occur. This is a picture of a superficial burn which shows epithelial cells migrating onto the wound from the edge, but there are also these islands of epithelial cells where epithelial cells are migrating from. So where are these coming from? These islands are coming from migrating epidermal stem cells. And this paper by Pastor et al., they show this diagram of where there are distinct niches of epidermal stem cells, and they are in the hair follicle, in the bulb of the hair follicle, in the sebaceous gland of the hair follicle, as well as in the basal layer of the epidermis. When an injury happens, these epidermal stem cells are recruited and migrate to epithelialize the wound surface. This study showed many different processes of epithelial keratinocyte migration. This is an immunofluorescence picture of epithelialization across the wound, and where in 2011 we just knew about TGF-beta, now we knew that there were many other players involved, and there is a very well-balanced communication between keratinocytes when they produce many different chemokines and growth factors, and their crosstalk with other cells in the wound, namely fibroblasts, macrophages, and others, and they also produce chemokines and growth factors. So this crosstalk is well regulated, well coordinated for normal epithelialization to occur. We still we know that when in 1962, Winter published its landmark paper, the epithelialization does not occur under a dry scab. So when the scab is prevented from being formed and moist wound surface is maintained, the epithelialization is much more rapid. So this holds true to this day. So what can go wrong with the edges? In this wound, because of the fibrin on the wound bed, the keratinocytes are separated also from the wound bed. They cannot attach to the wound bed to march across this wound. They are still migrating, but they are migrating downwards, and they cause the skin to become rolled inwards, and this is called epiboly. These are keratinocytes. This is the wound edge. For these keratinocytes to start migrating over the freshly deposited wound matrix, they need to lose their adhesions among themselves, as well as to lose their adhesions with the basement membrane. And then they develop different characteristics, and they migrate on the wound bed and reform these connections for differentiation and growth. These connections between the keratinocytes among themselves as well as the basement membrane are protein complexes, and this diagram just shows that the protein complex that attaches the two keratinocytes is desmosome, and the ones that attach the keratinocyte to the basement membrane are the hemidesmosomes, and they are made up of several more proteins and hundreds to thousands of amino acids and molecules. So many different molecules have to be dissolved and then reformed again during this migration and healing process. And there are many key regulators that play an important role in modulating this process. This is an electron microscope picture showing this 3D topography of the complex meshwork between epithelial cells, between the epithelial cells and the underlying basal lamina, as well as with the underlying collagen. In the epidermis of normal skin, there is homeostasis, and only the basal cell layers are dividing, and then they migrate up and they shed off. Whereas in chronic wounds, in all sorts of chronic wounds, this regulation is lost, and all the layers of the keratinocytes continue to keep dividing and don't stop dividing. So this results in this very thickened epidermis, which is hyperproliferative, it is non-migratory, and it does not re-epithelialize a wound. So back to the edge. When the wound is stalled, look at the wound edge. The treatment of epibole really goes back to the basics of wound bed preparation. And now, to end this talk, I will present a case which we recently healed at our wound center. This is a venous leg ulcer in an 84-year-old. When this patient presented to us, this ulcer had been present for one whole year. And he had received standard venous ulcer treatment for that time with moist wound healing, absorptive dressings, as well as 3 times a week compression bandaging. However, I don't think anybody paid attention to this edge, which you can see is thickened and appears devitalized. So I debrided this edge, and in just a matter of 3 weeks, continuing the same treatment of absorptive dressings and compression bandaging, there was good epithelialization on the wound. However, you can see that the edge starts to get some devitalized tissue again. So I did a repeat debridement of this edge, and within just a couple of days, there was robust skin formation on this wound. In another couple of weeks, the wound did contract, but then stalled again. And now the edges were looking like they were starting to roll in, and there was fibrin slough on the wound. So then I debrided the slough, debrided the edge again, and just in a matter of a few weeks, the wound healed completely with good mature skin all over this wound. So thank you for your attention. I will end here, and I will now have Greg present where are we now with epithelialization and how much more do we know now? Greg?
Thank you, Rummana. And I'm going to share my screen. And let's see if you can allow me to, thank you. Okay, share screen. And okay, so are you now seeing the sequence of, say again?
We see you.
Okay, well, let me escape here a second.
So in wound scene investigation presentations, we always interrupted each other and made jokes. So I just have to say something about how fabulous it is that our emeritus professors can handle these Zoom conferences.
Well, we don't do it well all the time here now. So darn, I'm sharing my screen, but
We get it. We've got it.
You got it with the, okay. So basically, what I just want to take a few minutes and update you a little bit. So in 2011, we knew some of the fantastic cell biology aspects that Bob talked about and that Rummana showed us. And we knew that one of the barriers to epithelialization was that the wound bed wasn't conducive to the epithelialization because it frequently didn't have the right proteins like the fibronectin that we showed in Sarah Herrick's paper where the fibronectin was totally degraded in the non-healing ulcer bed, but only after the fibronectin was able to be synthesized and stabilized was the epithelium beginning to move. And so we knew, that wounds would normally progress through these 4 phases of hemostasis, inflammation, repair, and remodeling. And in that repair phase is when the epithelial cells would proliferate and migrate across the wound bed because it had the right components. What we didn't know, we're just beginning to understand back in 2010, 2011, was that the reason many of these wounds failed to epithelialize well was they were stuck in this inflammatory phase, as I'll show you, where the proteases were very high. And so that meant that the wound bed, and especially the epithelial cells, couldn't move out of that into the repair phase and finally heal. So really the key was to try to understand what was preventing the epithelialization. Well, we knew that control inflammation is good. The neutrophils and macrophages, as you know, they generate and use these reactive oxygen molecules to engulf and kill the bacteria that are contaminating, colonizing. They also release these proteases, the matrix metalloproteases and elastase, to remove the damaged matrix that occurred during the injury so that new collagen and fibronectin, and especially the basement membrane, can reform so the epithelial cells would be able to attach and migrate. Now, what we didn't know in 2011, and which we now know, as indicated in this paper in 2017, was that monocytes, when they come into the wound bed at the very early phase of the inflammatory phase, they differentiate into what the field is called M1 macrophages. And these are very pro-inflammatory, very phagocytic and bactericidal. They secrete all of these pro-inflammatory cytokines. In other words, these M1s are there to essentially engulf and kill the contaminating, colonizing bacteria so they don't progress into more severe forms of the bioburden. Once these monocytes in the M1 phase have effectively reduce the bioburden in the wound, new ones that come into the wound then differentiate into a different kind of macrophage. They activate different genes and they secrete many types of pro-angiogenic and pro-healing growth factors, as well as anti-inflammatory. So this M1 makes the wound more inflammatory. The M2 makes it more wound healing. And just to make this ultra simple, if we look at an acute wound and early inflammation, we'll see both the M1 macrophages as well as the neutrophils. When they have effectively reduced the bioburden down to non-impairing levels, they will differentiate, and new macrophages coming in late inflammation do the M2, the pro-healing. What we now know that we didn't know in 2011 was that, as I'll show you, when the bioburden of both planktonic and especially biofilm bacteria elevate to a level, they get stuck in this chronic wound environment where the proteases and reactive oxygen species are continually elevating. Now, again, what we didn't appreciate in 2011 was that much of the biofilm, or the bioburden that's causing inflammation, is biofilm. Now, biofilms weren't new, it's just that we hadn't realized their role in chronic skin wound healing. So this review by DePozo and Patel in 2007 listed 18 clinical pathologies that had chronic infection caused by medical biofilms. But notice chronic skin wounds is really not included in that. So what happened is the field had to mature more, had to understand more of the role of biofilms in chronic wounds and how that can impair epithelialization. And so in subsequent studies, now we appreciate that almost all chronic wounds, when they really present as a non-healing wound for 6 weeks, almost all of them have some component of a biofilm, compared to the acute wounds that only have a very, very small percentage have biofilms. And in that middle panel, you can see what a biofilm looks like. It's this aggregate of bacteria encased in a self-produced exopolymeric matrix that contains proteins, bacterial DNA, polysaccharides, and this is incredibly inflammatory to our immune system, and that's what keeps the wound from moving out of the inflammatory phase and into the repair phase where epithelialization can begin. Well, again, and as the field has matured, this has led to this concept of early intervention with debridement. And as Rummana indicated in her patient, when she did the repeated control optimized debridement, the wound epithelium began to migrate and the wound went on to heal. And so this is this concept of step down, then step up treatment. The step down is start with your most effective aggressive treatment with antimicrobials that will reduce planktonic and biofilm. Then as the wound bed converts out of that inflammatory phase, you can step down to less aggressive debridement, just more maintenance debridement. Eventually, if the wound needs additional help to heal, you can step up to these advanced therapies. And so this is really where our new understanding of epithelialization is currently, is that we have multiple new advanced therapies that we didn't have in 2011. And those include especially the skin and the cell and tissue products like the basement membranes, the amnion chorion membranes, and other basement membranes that in the image that Rummana showed you, those are the basement membranes that epithelial cells love to attach to and migrate. So from 2011 to now, we understand better what's impairing the epithelialization. A large part of that is due to this bioburden with biofilms, how to try to control it, and eventually how to use advanced therapies that are especially helpful for epithelial cells to attach and migrate to. So I'll stop there and let Rummana review for you some of the practice pearls that have come about in the literally 10 years since 2011 when this was first introduced to the field.
Well, actually, I'm going to take over right now.
Okay, sorry.
That's okay. That's okay. So I also want to remind you that if you have any questions, to please go ahead and type it into the Q&A box that's at the bottom of your screen, and we'll be happy to answer your questions. What often happened during our wound scene investigations is that we usually packed a whole lot of information in and didn't have a lot of time for questions. So, so please go ahead and put your questions in if you have any. And so usually by the end of the session that we did, we wrapped up with some practice pearls. Because as Bob said, we wanted to make this something that it was bedside to bench. We took, and you know, we had Lillian and Bob and Greg as our scientists, all PhD and you know, in science, and then usually it was Lisa and myself, and then later Lee Ritzy, to bring the clinical cases to the group to have them help us figure out what's going on. And so, so these were some of the practice pearls that we closed with on the wound scene investigation relative to the epithelialization. And I think it's been clear. We have to have a good matrix in order for these cells to migrate out. We have to get rid of the bad. And briefly, Rummana had a slide looking at the DIMES concept of debridement, you know, making sure we have infection and inflammation down, looking at a moisture environment, as well as watching that edge. And when we talk about epithelialization, of course, the edge is everything. So we have to make that surface of the wound one that these cells at the edge want to migrate across, because what we'll often see are, and this is a picture, you can't see the far right picture, you can see with the scalpel just shaving down that hyperkeratotic edge. You know, when you look at a wound and you see this hyperkeratotic edge, those cells have ramped up, they're replicating, And so they express this integrin and they're going to move on out, but they sense that it doesn't have that fibronectin. It doesn't have a surface that's conducive to their migration. So they're just stuck at the edge, but they become thick. And we see this frequently with venous leg ulcers. So we want to always be watching that edge. And I'm a big proponent of good cleansing and good wound hygiene and being aggressive with our cleansing or assertive with our cleansing to the extent that the patient can tolerate it. But if we're not cleaning our wound beds, then we have a higher chance that a lot of bacteria is going to build up and then we're going to have more biofilm, and it's sort of a self-perpetuating problem. And so making sure we're doing good cleansing, good debridement, good maintenance debridement, keeping those edges open as Rummana has already mentioned, taking away any kind of inflammatory stimulus. And then, the heaped up cells, get rid of them and then figure out, okay, they wouldn't be doing that if I had a good wound bed. And then that's up to us as clinicians to figure out just why that's happening. So the bottom two pictures, sometimes you may not, a lot of times it's a nurse that's in the home setting or in a long-term care, someplace where they may not have a provider to help them address the edges. So, wound cleansing and good hygiene is pretty much all they have to prepare the wound bed, but also watching those edges. And sometimes we can just use a better absorption. If you look at that bottom left picture, that was a pressure injury, and you can see how thick those edges look, but mostly because they're macerated. So they're already thick, but they were also macerated. And so the next picture is just exactly 1 week later, and all we were using was an antimicrobial dressing to help to remove the bacteria or get the bacteria under control, but also to help to put a little bit of compression down onto those edges. And you can see that we had nice migration. So our wounds will talk to us if we just let them, and we take a good look and see what's going on, what is not happening, and then it's up to us as clinicians to figure out why. So with that, I'd ask everybody to come back onto their cameras, and let's see. I think we have one question here. Let me see what it says. Okay, so Heather's asking us. I don't know if you all want to read this, but I'll read it out loud. It's a little bit of a paragraph, but she's trying to heal a wound over a lateral malleolus in an area of a previous scar. Okay, let's address that scar in just a moment. So peri-wound is hypertrophic scar tissue. She's gotten it to less than 1 centimeter and it's stalled. The patient continues to work, to walk. She can't isolate her ankle movement. It's too small for a skin substitute. Cultures are negative. She's tried a native collagen endoform with hydropheric blue ready, and they're now 6 months out installed. X-rays are negative. CRP and SED-rate are negative for osteo. She's on an oral med called ibrutinib, and I'm afraid I don't even know what that is, for lymphoma, but their hematology oncology said they didn't think that would keep her from healing. So she's not sure. Wound seems to be stalled, and she began this. Boy, this would have been a perfect wound scene investigation patient. She's obese, well-controlled diabetic. So I think one of the issues, let's first try to think about for Heather is, what about a wound that's in an old scar? What does that do in terms of expecting normal cell activity if somebody has scarred in, or it's in the middle of an old scar? Who wants to take a stab at that?
Bob's the king of Scar Wars.
Yeah. Oh, you're muted, Bob.
Mute.
I think Lisa ought to hit that one. Oh, back to your court, Lisa.
Well, the lateral malleolus is particularly hard, whether it's scarred or not. And then the scar is going to make it even more difficult because it's poorly vascularized. Because by definition, that scar has less vasculature than normal skin. So you really, you're kind of in a rock and a hard place. And you're controlling for everything else. And you've got a monoclonal antibody for the lymphoma, which I agree, it probably is not impeding healing a lot because they're pretty focused. So they're certainly not as bad as some of the more broad spectrum chemotherapy agents. So you have to think about why is it not healing? Is it because the fibroblasts can't migrate because they're scarred, the epithelium can't migrate out of the scar? How can we make that a better environment? Is it ongoing friction because she is working, walking, can't isolate her motion? That often leads to unstable epithelium that, like in that very first picture that we showed in the flip book, where it just can't really stay attached. So I say try to immobilize it and keep the friction away and use something like a silicone dressing that might soften that scar a bit, and you might get some migration. Let's see what Bob has to say, or Greg, of course.
I'd like to say something that I've tried.
Yeah, Rummana.
I don't know if there is any inflammatory like redness or even a mild swelling around a wound. Sometimes that happens on the malleolus, even if they don't have edema on the leg. And that inflammatory fluid is always causing hyperinflammation and does not let the wound heal. So sometimes I do a layer of compression on the ankle to drive that fluid away, and it does help. It's just something you can try without having any harm to the wound. Just a thought. Greg?
Well, I would agree with what both Rummana and Lisa said, that obviously there's typically less vascularization into the scar, so that impairs the ability of the tissue to support the epithelial healing. I assume probably there's enough granulation tissue in there, but it's not exactly clear without seeing a picture. But what I would think would be reasonable to do is to try and use a advanced cell and tissue product like the Endoform, which has growth factors in it and is an intact basement membrane. But I think, Rummana, as you indicated, and Lisa, to try to prevent the shearing force that's occurring on on the malleolus. And so it's possible that it has the right molecular components to epithelialize and granulate, but the physical stress that's on that particular part of the foot can be so substantial that unless there is a physical dressing or physical approach to try to let it epithelialize before it gets sheared off, I think that would be it. The well-controlled diabetic, okay, obese, okay, yeah, those are some other things. Final is there are some newer-ish products and approaches where they actually use the secretome produced by human vascular stem cells or mesothelial cells. And there are early reports of those types of products being used to really stimulate both the new granulation tissue formation as well as epithelialization. And so if you do all the other things so that the wound isn't constantly being put under physical shear forces, it's possible that it would heal, or you could give it this advanced treatment that's available in a few places now, where they use either autologous stem cells or they use commercially available secretome produced by cultures of human stem cells, and they contain all of the growth factors and the exosomes and everything that the stem cells use to promote healing. That was probably a long answer, but you know.
No. Well,
No,
once again, it's the matrix is the problem. The epithelial cells are not going to migrate into a dense collagenous matrix. That has to be removed somehow. And then the epithelial cells need the proper basal lamina in order for them to cover that wound.
So I
And,
went away.
and the endoform does that pretty well. Go ahead. Sorry, Dot.
No, that's okay. That's okay. You know, I think we sometimes don't appreciate what the role that edema might play in a peri-wound area. And so while this is less than 1 centimeter, you know, some of the newer ambulatory negative pressure devices, there are some that are just a silicone dressing instead of a foam, and that might, you know, would cover it nicely and might keep it protected, as well as lift off the surface, as well as flatten out the edges. So you might want to consider one of those.
Yeah.
That's a good idea. Yes,
Yeah,
that
because, you know, when
it brings the edges together also, and prevents the shearing forces, and it may you know, equalize those forces, because epithelial cells will definitely not migrate if there's traction and forces, shearing forces.
And it might actually get paid for, unlike the secretome and the stem cells.
Yeah.
Yeah. So Heather said she tried compression, and I have had this experience as well, that over the lateral malleolus, even a small amount of compression in a healthy person can be too much. It's just because of the way the stockings are, they put, if you've worn them, it puts a lot of pressure on your malleoli. And so I agree. So I think that negative pressure idea you might be onto something there.
And I would add that some of the most dramatic things I've seen with the negative pressure is to, when the wound bed is prepared well, to put down a cell and tissue product, and basically a basement membrane product like endoform, like the amnion membranes, and then put an interseed kind of layer, and then the vacuum matrix, you know, the open cell foam matrix down on that. And the granulation tissue forms very rapidly in that. And as Bob said, the epithelial cells then have the matrix that is optimal for them to migrate across, because it's essentially an intact basement membrane.
So Dot, there are several comments.
Yeah, so some other people have chimed in, and I'm just going to read it because also on review of ibrutinib, this is a tyrosine kinase inhibitor that has 12 to 29% incidence of skin rash. And this person said they don't think they fully understand how these new chemotherapeutics actually can impact the skin. So we're probably all learning again as we go along. And then in addition to a regular, someone was just talking about using honey, a honey product to probably, you know, honey will cause a fluid shift, so that could help with some of the peri-wound edema and also create a nice environment. And so this person, he, I think, has a 70 to 90-year-old, that population. Okay, you know what, he wasn't, okay, we're going to come back to that. I apologize, they weren't weighing in on Heather's problem. So Heather said, what type of silicone dressings do you recommend? The silicone that I was talking about is incorporated in 2 different negative pressure devices that are on the market. So instead of having a cartridge or a canister that the fluid goes into, it actually, the negative pressure is delivered into a silicone dressing. So Heather, my email is .weir55@gmail.com if you want to email me separately. So that's just my name, Weir, and then my year, my birth, 55@gmail.com, and I'll be happy to give you some more information about that. And then Sandy Rosenberg weighed in and said she would look at her footwear. Often people, especially people with diabetes, have decreased sensation and get sheared when they don't even know it. So hyperpronation can worsen this on the lateral malleolus, and it's also could elevate the patient, help to evaluate the patient with lymphoma as far as their nutrition. So gosh, lots of people helping you on this. So, okay, so I think we'll see, there was one other because we're 5 minutes out. Angie says she's used microlight matrix to reboot or get a stalled wound active again. But I think we had one from Nicholas who was looking at something different. Okay, Nicholas says, in addition to regular debridement on lower extremities, secondary intention wound status post Mohs, he has incorporated non-judicious use of Medihoney gel with regular increased rates of epithelialization across his 70 to 90-year-old population. And do we have any experience with this product? If so, how often do you do dressing changes? So Lisa, do you use honey?
No. I use a scalpel. So, so Medihoney really, I mean, what it's promoting is a moist wound environment and autolysis. And most of the wounds I treat are too wet, and I don't need to be adding anything more. I know it's very popular, but it's just the population that I treat is different. I do have to commend you for not using Vaseline on the Mohs defects, which is what I often see.
Yeah, we do too. You know, I mean, honey is anti-inflammatory in its own right because it doesn't support any kind of bacterial growth. It will also cause an osmotic shift of fluid out of the wound bed. Good for desloughing. That was their original studies were in desloughing out of Scotland. So yeah, so but from a protocol standpoint, we have the patients change it usually just twice a week. It is so wet that that we usually don't have to. It's not like a hydrogel. We can change it less frequently than that. And then we make sure the patients are watching their peri wound because it does create a lot of moisture, and then you know, then you may have maceration issues. So let's see.
There was a question about the winter paper and the epithelialization under the scab. Lisa, were you answering that question?
Yeah, I think what Winter showed, not that it wouldn't reepithelialize, but it was the rate of reepithelialization much faster in a moist environment. And yes, the cells will migrate under the scab, but they're really slowed down. And I tell my patients, you know, who all want to leave their wounds open to air, I was like, that worked when you were 20, but it doesn't work when you're 70, 80, 90 years old, because they have lots of other impediments and everything gets worse.
Yes, so that's right. It does epithelialize, but the rate of epithelialization is twice as fast when it is moist. Okay. So I think I will ask Katie to share our emails with all the registrants. If they have any more questions, please feel free to email. Yes, Doctor.
Just Nicholas came back and said, please elaborate on the Vaseline. That is very often what we use. That's why I joined. Do you want to weigh in on Vaseline?
Yeah, so I mean, so does it keep the wound moist? It is a petroleum product. It's not water-based. And I see a lot of patients coming to me 3 months after their dermatologic procedure, doing exactly what their dermatologist told them to. And, you know, thank you, patients, for following directions, but they still don't have a wound that's healing. The literature on Vaseline showed that it reestablished the barrier function of the skin, but that's pretty old data. I think there are better things now that can help keep the wound moist and are accessible to patients. Dot?
Okay, well, we're right at the top of the hour. Gosh, we are so thankful. You know, if you guys haven't looked at the Q&A section, there's been a lot of interesting things that have popped up. So this has been such a wonderful reunion. So I thank everybody for all of you all for joining us. I thank our panel, for Rummana for working so hard on this presentation. All of you guys, it's just been great. So with that,
I just have a couple of final reminders. Dot, I'm sorry, I didn't mean to cut you off, but
no, you should have cut.
Okay.
Yeah.
So anyway, this was the first of the series in the webinars for Chronicles of Wound Scene Investigation presented to you by the Wound Healing Society Education Committee. Just to remind everybody that this recording will be available in the members only section in the Wound Healing Society website in the next couple of weeks. The next webinar is, please mark your calendars, February 8th at 6 p.m. Eastern Standard Time and will be presented on the topic of osteomyelitis by Lisa Gould. So, okay, Dot, you can say goodbye now.
Yeah, no, and then March 8th, we have March 8th, which is going to be also at 6 o'clock, and it's going to be about the chronic wound environment. So,
Woohoo.
yeah. So anyway, well, thank you everyone for joining
Thank you
us.
very much.
And we'll see you at the next Wound Scene Investigation Chronicles.
Thank you. Stay safe.